Morning. Right. All right, why don't we get going? Good morning. All right. So potpourri today. So this is a newborn who has this arrhythmia. So what is the arrhythmia? What is the workup? What is the natural course and treatment? Why don't we go with Dr. Zawani, since you will be dealing with more newborns than the rest of us.
Morning, Dr. Pass. Yeah, so looking at the rhythm, because initially it looks like we have sinus rhythm, but then starting the 6th beat, it's not. We have an narrow complex tachycardia.
Well,
wide. Yeah,
okay.
wide. Let's see. Yeah, I think with this now, see the rate. So I think a rate of around like 1.
So it's a little faster than the sinus, right?
Yes, around 180 or 167.
Yeah, it's a little hard to tell since the boxes are very this is a very old tracing from about 12 years ago. So. Okay, so what is this rhythm, do you think?
Yeah, so maybe it's ventricular tachycardia.
I agree. I mean, this is a wide QRS. It's not very wide, right? But one of the points that we always want to make it with babies is doesn't have to be very wide to call it a wide QRS tachycardia. And in this particular case, the QRS is pretty wide. Now, the other thing is there anything you can say about this tracing here? And is there anything meaningful you can say about the atria and the ventricles and the relationship? Look at any of these strips, really. Is there association or dissociation here?
So dissociation, yeah.
Right. So there's both VA and AV dissociation. So this is an example, a very nice, clear example, excuse me, of somebody who's having ventricular tachycardia with ventricular atrial dissociation. Okay, so baby looks fine, but definitely neonatal staff is seeing this a lot. And what do you think, what would you do about this? How would you evaluate and deal with this?
Yeah, so I think when the patient is on the tele, I think so. One thing we can see if the check if how the patient is hemodynamically stable or not with the blood.
Baby looks fine.
Yeah.
Good perfusion. Blood pressure is stable. It's actually eating fine. It's otherwise well.
Yeah, so I think the other assessment will probably will be an echo.
What are we looking for on the echo, Tarek? I agree with you. We should do an echocardiogram. What are we concerned?
So I think the first thing will be to see if how is the heart function, even though clinically we assess that the
Yeah.
patient looks stable, but
That's reasonable. You could have a tachycardia-induced myopathy.
Yeah.
Although with this amount, if this is the frequency, we would hope
Mhm,
that you would not get myopathic. But
mhm,
so let's just say for the sake of discussion, the
mhm.
function is normal. Anything else we'd be looking for on the echo?
Yeah, and then I think any covered malformation that was not detected.
Such as what?
Um, okay,
What could cause PVCs in babies?
so the cardiomyopathy was the first thing, right? And
Cardiomyopathy is a possibility. You
uh-huh,
also want to think about rhabdomyoma, right? I want to make
rhabdomyoma.
sure that someone doesn't have. Sometimes in a baby, it wouldn't be as obvious. You want to make sure you don't have a rhabdo or another kind of a tumor. There are these reports, mostly out of Texas, of people who have Purkinje cell tumors, particularly in the left ventricle.
Yeah.
This seems not to be left ventricular in origin, but definitely you would want to look to make sure you don't see that. Although quite frankly, I've never seen that, but that
Yeah.
is certainly well described. Okay, so the baby, the echo looks basically normal. So what are you going to do? Are you going to treat this, watch this? How would you?
I think the recommendation I think initially would be to watch because the patient is asymptomatic. Um, so
Well,
from
I think you would first observe in the hospital,
yeah,
right?
yes,
See
yes,
how
yes.
frequent this is. Let's say that the patient is having this degree of frequency. So the first question is, what is the natural course of this? So the family, you tell them and they come back the next day and they're like, Dr. Zawani, I'm really freaking out. I just looked up ventricular tachycardia. It's very dangerous. What are you going to say to them in regards to the natural history of this?
So I think initially it would be that the natural history would likely, since the evaluation was negative, I mean, for any anatomic etiology, that the expectation would be for it to subside.
Yeah, this usually resolves by a year of age. The majority of patients will have this resolve. So the natural history is very positive. It's good. How do you decide if you're going to treat this?
Yeah, so I think the the question is the symptoms. If the patient is having like while in the hospital being watched, or like at home having difficulty feeding, or having
So would you expect this to cause symptoms?
no.
Not usually, no. You're
Yeah.
right. Correct. Doesn't usually cause symptoms unless, of course, you're stuck in it, and then you could develop tachycardia-induced cardiomyopathy. So really the decision to treat is based on how much of this a patient has and how worried you are that they might get stuck in it or
Yeah.
alternatively develop dysfunction as a result of it. I think if I had a patient who was having this degree of ventricular tachycardia, this much of it, this amount, I probably would treat this patient.
Okay. So then
So you've called your cardiology consult. Dr. Kong has come down. She's said to you, "Well, what do you want to do, Tarek?"
so
And
a beta blocker then.
yeah, you could try a beta blocker. I'm not 100% sure it'll work, but that would certainly be the most common first agent that we would try. And what would you use, Tarek?
So we'll use propranolol, and then we'll
Yeah,
start at
yeah.
3 milligram per kilo per
I
day.
mean,
But
3 per
then yeah,
kilo is a pretty aggressive starting dose. Remember that the therapeutic dosing is 1 to 4.
yeah.
So unless I'm treating something I'm very, very worried about, like a patient with long QT syndrome where they're having tachycardia, I would usually start at about 2 per kilo. You have to be
Okay.
careful with beta blockers in small infants. They can actually get very, very sleepy, and it's fascinating if you take a baby who's been, let's say you have a baby who's been on a beta blocker for say 6 or 8 months and they have SVT, and they come into the emergency room with a bad breakthrough episode. And so you decide, all right, I'm going to stop this and put them on something else. And you admit to the hospital and you put them on flecainide or amiodarone, for example. The family will universally, the mother will tell you that the baby is much, much more alert when they're not on high doses of beta blockers. So I'm not a huge fan of these 3 and 4 milligrams per kilo doses. I don't think there's anything wrong with it. It's not dangerous. It's not wrong, but and there are cases where it's absolutely critically necessary. But if I don't have to go very high on these doses, I do have marginal concerns about neurodevelopmental outcomes in people who are so sleepy for much of their early childhood. Now, again, if you have a very life-threatening condition like long QT syndrome and you've had a couple of episodes of torsade, I would be much more concerned about that than any theoretical benefit on or effects on neurodevelopmental outcomes. But I do think that you should always be wary of giving very, very high doses, and I would put 3 to 4 per kilo in the high, certainly in the high dose range.
Sounds good.
Yeah, so you would try that, and if that failed, you could give amiodarone. That wouldn't be unreasonable. Amiodarone is very commonly used in infancy outside of the US because surprisingly, amiodarone is very easy to obtain outside of the US and is very inexpensive. So in a lot of countries, it's given as first or second line therapy for almost all tachycardias in babies. And the other nice thing about amiodarone is because of its very long half-life, it can be given once a day. So compliance tends to be better with amiodarone. And, I think in an infant where you're planning to stop the medication in a 6 to 12 month period, it's not at all unreasonable to do it. We don't usually use it just because the theoretical side effects associated with it, but I think an argument could be made that we're a little too worried about that, given the relatively short period of time that we're using it in small children. So, all right, very good. Thank you very much.
Thank you.
Okay. All right, let's move forward. All righty, this is a tracing I show about 3 times a year. So some of you have seen it 6 or 8 times already. This is a tracing from an 8-week-old who had a Ross-Kono operation. And in the middle part of the tracing, we are looking at atrial pacing. And the question is this an example of a person who is in VT or junctional ectopic tachycardia? And I will ask this question of Dr. Abdul Karim.
Good morning.
Good morning, Ali.
Let me see. I know we discussed last time, like postoperatively, would worry about junctional ectopic tachycardia postoperatively.
Well, I mean, JET is very common after a lot of congenital heart surgery. So yeah, that would be a concern. I mean, what is actually the most common abnormal rhythm patients have after a Ross-Kono? Do you know what a Ross-Kono is, Ali?
I guess I know what the Ross is, but I don't know if I don't know what Ross-Kono is.
So Kono is an operation where basically a VSD is created. It's for patients who have subaortic stenosis that is very severe. And it's typically an operation that's done in someone who has already had a prior surgery that was ineffective at relieving obstruction, or that resumed or came back. So in a Kono operation, and again, I'm not an expert on this, but basically the surgeon effectively creates a VSD in order to reduce the amount of subaortic tissue that exists, and then closes the VSD. But in closing it, has taken a tremendous amount of muscular tissue out of that area. It's a very, very aggressive form of subaortic resection. So what would you imagine would be a concern of that type of surgery? any important structures.
I guess you'll be so
Electrically.
concerned about the conduction pathway
Yeah,
going through this area.
absolutely. One of the best ways to ablate the AV node, in patients who have atrial fibrillation, one of the old-fashioned treatments was to ablate the AV node and just put somebody on anticoagulation and put in a pacemaker. And one of the most common ways that it was done was to pass a catheter retrograde across the aortic valve and find the His bundle and just blast away. And this was also done a lot of the times in patients in the old days when, Fontan patients would have flutter, and in an era before ablation for flutter or IART in Fontan's, this was a technique that was described, was to ablate from the left side. So you're absolutely right. If you're resecting the left ventricular outflow tract, there is a not insignificant chance that you could get complete heart block or at least high-grade block. But that is clearly not the case here because we are conducting on these paced beats. So, and of course, anytime you're around the ventricular septum and doing resections and suturing and all, there's always a chance for jet. So I certainly agree with you that jet would be a concern in this operation, although it would be, as it would in any surgery involving the ventricular septum. So what do you think, VT or jet, and why?
I think when I look at I'm trying to just follow what the QRS pattern looks like.
Yep.
Through the I guess it would have been helpful to get let me see 1 second. Just trying to follow like what the QRS pattern looks like throughout and
So-
see if it changes. But
Right.
I guess it looks initially like in the first 1, 2, 3, 4 QRSs look the same, and then it kind of changes its pattern.
Uh-huh.
And
And
so this
remember,
could be
we're
maybe
only
more,
the outsides of this are the arrhythmia, and the inside is apaced rhythm. So basically,
right. Oh yeah,
arrhythmia,
yeah.
arrhythmia. This is all apaced in the middle. I mean, there's apacing here, but it may not have caught up with the rhythm at that point.
I guess just like it starts to look different.
Uh-huh.
The QRS, it starts to look wider.
Okay.
So maybe it's VTAC, because if it was jet, it would have been the same throughout.
That's exactly right. So very good, Ali. So in people who have jet, the QRS morphology should look exactly the same in sinus rhythm and in jet, because junctional ectopic tachycardia theoretically is arising from the bundle of His. In Europe, the most common term for jet is His bundle tachycardia. And so patients who are having tachycardia from the bundle of His or from the AV node should have a QRS that looks exactly like sinus. But when we are apacing this patient, we see that the QRS is different. And in some leads, it's wider, I agree. In others, it's narrower. I think overall, the QRS is about the same in terms of its width, but it has clearly got a very different axis, different morphology. So this is actually a patient who has ventricular tachycardia. And with apacing, this is a nice demonstration of whatever is fastest wins in the heart. So in this case, apacing at a rate faster than the VT rate suppresses the VT, and the patient remains in apaced rhythm. So how would you manage this? So you've demonstrated that you've demonstrated that this is likely to be VT and not jet. And you've demonstrated that you can apace and maintain, essentially go down the AV node and suppress the ventricular arrhythmia. So I'm going to ask Dr. Barris. David, if you had this, how would you manage this? You're up in the ICU and they're asking you what to do.
Well, I first want to know how persistent it's happening and how hemodynamically significant it is?
All right, so it's happening pretty much all the time. And the blood pressure is acceptable. The perfusion is adequate in this arrhythmia. And we are, let's say we're post-op hour 3 after surgery. It's like this is a big operation, a Roscono. So let's say it's 8:30 p.m. Patient came back at 5:30 from a big operation. It's 8:30, you're on call, and the nurse practitioner is showing you this tracing. You're at the bedside and you're trying to decide what to do.
Yeah, I mean, I'm thinking whether, I'm kind of weighing, the fact that the baby's hemodynamically stable versus the fact that the baby just had surgery and it's happening incessantly.
Mm-hmm.
And I wouldn't want to, I don't think I'd want to leave the baby in it for too long.
Right. Why is that? We've just established that the patient looks okay, is adequately perfused. Why would you not? I agree with you, by the way.
I
would
think
not want to leave
because
the patient like this, but
I think just because you're also having the VA dissociation, which would be not great for our cardiac output, especially after the procedure.
well, that's true, but I would caution you to be particularly concerned about that, the VA dissociation. VT is VT. It's still not optimal in terms of hemodynamics, even with VA. Even if there were one-to-one VA conduction, it would still not be good for the patient overall. But go ahead, Dave. Sorry to interrupt you.
So we can do lidocaine if we want to kind of get rid of it. Would be one option.
Right. That's not an unreasonable choice. Lidocaine is, the other thing I would just remind you is that if you have a patient who's 3 hours following surgery, it's likely we're going to go into a low cardiac output state, right, 6 to 8 hours after bypass. So the fact that the patient looks okay at the bedside 3 hours after a very major operation, which likely will have a long bypass and cross clamp time, would not give me comfort that this patient is going to be stable. So yeah, lidocaine is not unreasonable.
And then, the thing is the baby's just post-op, so I don't think we have enteral options like the propranolol that we were talking about earlier.
That's correct. Enteral therapy would be generally inadvisable, although in some countries people do that, but I agree with you. I don't like the idea of variable absorption in somebody whose gut may or may not be working at this stage.
And then there's amiodarone.
Right. You could use
that's
amiodarone, sure. Any other agents you could try? I agree with all of these choices, very reasonable.
Procainamide is another one.
Yeah, procainamide might be also a very reasonable agent to try. What if I told you that the hospital just ran out of all antiarrhythmic therapy? There's no antiarrhythmia medicines. Is there anything else based on this tracing that you could do?
Well, it looks like we can also pace the patient.
Right. So if you pace the patient, we're demonstrating that we can suppress it. So, if you had said to me that you would like to not treat it, but instead pace and just suppress it, that would not be an unreasonable approach. I would not favor that exclusively. For sure, I would pace, right? Because as long as you're paced, you are not in VT. But the reason to treat medically as well would be to prevent the possibility that the rhythm was going to accelerate and you would lose capture and lose AV synchrony. So I think that pacing would definitely be part of the acute management of this, but you would want to at the very least slow the rhythm down so that the patient, maybe sinus rhythm, would overtake it. So yeah, that's what I would do. I agree with you. Good. All right. Very good. Let's move forward in this potpourri. All righty. What are the borders of the triangle of Koch? Let's see if Dr. Bebbia can remember these.
Good morning, Dr. Bass.
Good morning.
So the three borders of the triangle of Koch are the tendon of Totoro, the anterior leaflet of the tricuspid valve, and the mouth of the coronary sinus.
Very good, doctor. And why do we care about the triangle of Koch? What structure lives in the triangle of Koch?
AV node.
That's correct. So always something we're very worried about. So I like the way you remembered the hardest one to remember, the one everyone always forgets, which is the tendon of Totoro, the mouth of the coronary sinus, and then the anterior leaflet of the tricuspid valve, which constitutes the triangle of Koch. And we believe that the compact node is sitting somewhere up here. And so when we're doing our so-called slow pathway modification for AVNRT, we are trying to burn down in the lowest third of Koch's triangle on the theory that a patient should not have any conduction tissue in that region. Of course, not everybody's heart has read the textbook, and this is the reason why rarely patients can develop heart block during ablation for AVNRT because of that. Sometimes you've heard me or Barry comment that someone's triangle is very flat or not very large, where the top, and in this way, it's not sort of a nice broad triangle, but in some patients, the top and the mouth of the coronary sinus are almost on top of one another. And in those cases, we get a little bit antsy about doing a slow pathway modification in that region. But yes. All right. Very good. All right. So this is a Holter tracing from a 15-year-old who has an irregular heartbeat, and this tracing is obtained at 3:30 in the morning. I'm going to ask Dr. Marshall if she has any thoughts on what this is and what she, if there is anything that ought to be done as a result of this observation.
All right, good morning.
Good morning.
Let's see. So first, glancing at it, you can see that the first beat, the QRS is narrow, and then the next, let's see, 5, we see a change in our QRS morphology to a wider complex.
Yeah.
And then it goes back to narrow. And then, so first looking at that first beat appears to me to be sinus. It looks like the PR interval is reasonable, to where I think you're having, AV conduction. And then looking at the next ones, I'm not as convinced. Even on that second beat, it looks almost like like that QRS is coming in early. Yeah.
Mhm.
And then after that, I'm not really, unless it's the P wave at the end of the T wave there, but I'm not seeing a P wave preceding. So this would make me think that this is some type of like ventricular escape.
Yep. And I like the term escape rhythm rather than tachycardia, because it really is kind of what that is. So this is like a person whose sinus node is getting a little slow, presumably during sleep. And remember, again, whatever is the fastest in the heart usually wins when it comes to rhythm. And so the sinus node slows and the patient has a somewhat accelerated ventricular rhythm for a couple of beats. And then eventually the sinus node sort of perks up again and suppresses this. So is this concerning, worrisome?
I'd say, I would like to know, like, and since we have the Holter, I guess we know how much it's happening, and if it's happening not in relation to sleep.
There is none of this at any other time of the day. And this happened, why don't we say 3 times. This is the longest such run.
Okay. I would say it's not as concerning, given that it's during sleep and it's doing, the heart is doing, as you mentioned, whatever's fastest wins out. And so when the sinus node is slowing, you have these cells with inherent ability elsewhere in the body to pace or to set the rate above that. So I don't think I would do anything pending, like you said, there was no other abnormalities.
Yeah, I would agree with that. We do see this occasionally. It's a little unusual. We don't often see ventricular rhythms like this. the common question that someone like me will often be asked by cardiologists is, would I follow this? And I think that if a patient had nothing else of this nature, had a structurally normal heart with normal function, didn't have any worrisome symptoms, I probably would not follow this. Assuming the QT interval is normal and all of that, there's no history of sudden death, et cetera. In an otherwise well person, I would probably not follow this if that was all that we saw. So, all righty, guys, thank you for joining today. Just as an FYI, next weekend, I'm going to the SCAI and the HRS meetings both, and I'm going to be coming in very late on Sunday. So we're not going to have EP conference because I'm not sure I'm going to have the stamina to come in quite that early. So we'll have a break next week and be back the following. Okay. All right,
Thank you.
everyone. Have a
Thank you,
great
Dr. Price.
have a great day. I'll see you guys in our conference room in a short while for those who can make it.